Welcome to part 2 of our Microlearning series on management of chronic lymphocytic leukemia. This is medical oncologist Dr. Neil Love. I met with Dr. Mazyar Shadman from the Fred Hutchinson Cancer Center, University of Washington in Seattle, Washington, for a 2-part discussion that can be viewed or listened to in pieces or all together. Today on part 2 of this program, Dr. Shadman comments on 3 cases presented by oncologists specializing in CLL research and treatment. Dr. Daniel Ermann from the Huntsman Cancer Institute at the University of Utah in Salt Lake City, Utah, Dr. Shazia Nakhoda from the Fox Chase Cancer Center in Philadelphia, Pennsylvania, and Dr. Mahesh Swaminathan from the MD Anderson Cancer Center in Houston, Texas. We begin with Dr. Ermann, who has a young patient who elected to participate in a clinical trial of upfront management of CLL.
This was a 44-year-old man. He presented initially and diagnosed in 2021. He was RI stage 1 and was found to have progressive cervical lymphadenopathy. His CLL was IGHV mutated with trisomy 12, deletion 13q complex karyotype. So he actually had his complex karyotype actually fit with one of the few more favorable prognostic factors, given he had a trisomy 19. But regardless, he eventually did develop progressive fatigue anemia and worsening lymphadenopathy, unintentional weight loss, meeting treatment criteria. At time of progression, his white blood cell count was around 80,000, hemoglobin 10.6, platelets 200,000. Bone marrow biopsy showed packed involvement with CLL and reduced hematopoiesis. He had diffuse adenopathy above and below the diaphragm. We discussed therapy options with him. Given that this was in 2023, we did not have FDA approval of AV, acalabrutinib venetoclax at that time, but we discussed all options, including the MAJIC trial, looking at acalabrutinib venetoclax versus VO, and he was enrolled on that trial and was randomized to the acalabrutinib venetoclax arm. On this trial, after 1 year, there's MRD assessment, and he was MRD detectable, so he completed 2 full years of acalabrutinib venetoclax. Even by the first year, he had a complete response, but his bone marrow did show MRD detection. His end of treatment, he had a very, very excellent response, and he tolerated the therapy well, and currently I have him on surveillance. Question to the faculty: how do you think, with trials like the MAJIC trial, looking at MRD and PFS, how that may play out in the future? And do you think that perhaps one may be superior in regards to PFS than the other? And maybe I can ask this to the faculty. Do we need to really drive decisions based on MRD status alone? Should MRD status be a proper endpoint, or is really clinical response a better driver of when to discontinue therapy? Question for the faculty. So this patient had complex karyotype, 3 or more abnormalities. Now, generally, there's no specific treatment decisions we base on complex karyotype, but we do make a lot of decisions on TP53. Do your decisions ever factor on complex karyotype, and would you consider it to be as high risk as a TP53? And if so, what kind of treatment choices would you choose for patients like that?
So, any thoughts?
Sure. First question about the MAJIC trial. As a quick reminder, MAJIC compared acala plus venetoclax versus obinutuzumab, but that was not the only question the study was asking. The second question was if patients were either in a PR versus a CR, and if they had detectable MRD at the end of that 1-year therapy, they received another year of treatment. So the study is also asking the question of, is there a benefit of addition for an extra year of either ven or acala ven in patients who don't achieve a MRD negative CR? So I think it is an important study. I think it will help our practice a lot for both regards. It's unknown. I think as somebody who's involved in this study, we are eagerly looking for, it's a blinded study, so we'll see some results in future. And yes, and I think this will be the future of our clinical trial designs. We have to study both combination and also the impact of MRD. I think MRD is a very complex discussion in CLL. At the end of the day, we all understand that clinical endpoints matter the most, right? So if you have a patient who's in remission for 15 years and you tell them you have 0.01% CLL in your bone marrow. Do they really care? Probably not, right? But at the same time, they're on long treatment. So MRD eradication or undetectable MRD is relevant when we're looking at fixed duration options. And then the question is, can we use undetectable MRD as a surrogate for PFS so we don't have to follow patients for 15 years to read a clinical trial? So, and that's an active discussion, and a number of experts are in discussion with different authorities to see if that's doable or not. My personal opinion is, for any individual fixed duration therapy, obviously, if you achieve an undetectable MRD, it's better than not achieving an undetectable MRD. But the second question, if you're comparing between different treatment modalities, is MRD a surrogate for PFS? And I don't think that's the case. What does it mean? I don't think if I compare venetoclax plus obinutuzumab to a BTK inhibitor plus a BCL2 inhibitor, the MRDs have the same meaning. The MRD is meaningful in the context of the treatment. On the other hand, I just mentioned the Celestial 2 trial that we are about to open. And that study is comparing sonrotoclax, zanubrutinib versus acalabrutinib, venetoclax. So now you're comparing two exact same modalities, BCL2 plus BTK inhibitor. And if you stratify that study for IGHV status, then MRD has to correlate with PFS. So it's really the matter of how is that MRD or undetectable MRD created, or how did we achieve that? And are we looking at IGHV status? Because that's an important effect modifier or stratification factor. That's very complicated, but in clinical practice, I don't act on MRD in terms of treating patients because they have reappearance of MRD. And to continue treatment beyond, let's say, 1 year, as I said, based on what I understand from Sequoia-D and maybe a little bit of a UK FLAIR study, and also the AVU study of Dana-Farber, I think for high-risk patients, it makes sense to continue treatment longer in patients who have a detectable MRD. The question about complex karyotype is also an important one. I personally follow and support the viewpoint and guidelines by the ERIC group, and that's European Research Initiative on CLL. They have a nice position paper on this. The bottom line is that complex karyotype in the era of novel agent should be really looked with more detail than just somebody having complex karyotype or not. When we use novel agents, especially in patients who don't have P53 aberration or in patients who have low or intermediate complex karyotype, we don't really know if complex karyotype is an adverse factor. Also in patients, for example, who have trisomy 12 and trisomy 19, and the ERIC studies again showed that those patients actually may not do bad even if they have complex karyotype. So for super high risk, so if patients have more than 5 and in the context of P53 or unmutated IGHV, that would be an important factor, but it's a really dynamic field, and I won't use it as a 0-1 or black or white factor, and I don't use it as a sole factor to define a disease as a high-risk disease.
All right, so let's move on now. Dr. Nakhoda, as an older patient, now 72-year-old man, I'm curious what your thoughts are. Here we have a high-risk situation. Here's the case.
This is a 72-year-old gentleman with history of CLL. He's been on observation for bulky adenopathy. He has a TP53 mutated disease. He also has a Notch1 mutation and trisomy 12. And he really had been reluctant to start therapy. The most important thing for him is really mitigating toxicities. And I think he was really at the point where the lymph nodes were getting so bulky that I was kind of worried about complications for him. And so the question for the audience that I have is, how are you talking to patients about therapy in the setting of TP53 aberrations, especially in patients whose main goal is to mitigate toxicity and avoid long-term side effects?
So what's the follow-up on the patient?
This patient ended up starting zanubrutinib, and he's done really well on therapy. He had some expected side effects with the zanubrutinib. The biggest issue was he had a lot of more bothersome than actually majorly concerning issues with this, but the bruising was a big nuisance for him with the zanubrutinib. But otherwise, he tolerated really well. He had that expected lymphocytosis that we typically see with BTK inhibitor monotherapy, but it came down really nicely. Unfortunately, he still has some mild lymphocytosis, but his platelets and hemoglobin really are back in the normal range now. And, we're just going to watch him with this low burden of lymphocytosis now. So there's a lot of data out there looking at acalabrutinib and zanubrutinib, but there's not really been much randomized data here. Looking at the different data in patients with del17p or TP53 mutations, how do you counsel patients on starting either zanubrutinib or acalabrutinib? In what scenario would you consider a regimen like AVO, where we have some phase 2 data? And potentially, is there a scenario where you're using a zanubrutinib doublet based on some data that we have there?
Any thoughts about this one?
Great question. So for patient with bulky disease with P53 aberration, continuous monotherapy with a BTK inhibitor is, from the PFS and efficacy standpoint, is considered to be the treatment of choice. One of the second generation BTK inhibitors, either zanubrutinib or acalabrutinib. And maybe I answered the second question of how do you pick between the two. Obviously, there's no head-to-head trials. So I tell you how I think about it. So number one, the largest prospective study using a BTK inhibitor for P53 aberrant population is Sequoia C, so 110 patients, and we have the 7 years efficacy that looks pretty similar to patients without P53 aberration. There is some data from the Elevate TN, but much smaller cohort. So first of all, I mean, there's more data in terms of having prospective trial data. In terms of the relative efficacy of the two, again, we have done indirect comparisons, and this is now coming from the second line or previously treated setting. But in Alpine trial, we looked at Zanu versus ibrutinib, and the study had a predefined question of looking at subgroup of patients with P53 aberration, and there was a clear benefit of zanubrutinib over ibrutinib. Now, when you look at the similar studies that compared acala versus ibrutinib in the relapse setting, Elevate RR, and understanding the difference of the studies and designs and inclusion and the timing, there was a non-inferiority with a hazard ratio of 1.0 with acala versus ibrutinib. Does it mean that I can compare the two drugs head-to-head? But the way I explain it to the patients is exactly what I just said. We have two drugs. They're both well tolerated. One drug has been shown to be superior to ibrutinib, including in high-risk group. One drug has the largest cohort and long follow-up with del17p. So there is a potential efficacy benefit for one, and we don't have that evidence for the other one. And, it's hard to kind of to not go with the drug that at least potentially has the efficacy. So zanubrutinib gives you a better flexibility in terms of dosing, and also both the schedule once a day, twice a day, and also you have more room for dose reduction as needed. So my personal choice, based on what I said, which is not a direct comparison, is Zanu, but it's absolutely reasonable to use acalabrutinib. The AVO regimen that was mentioned by Dana-Farber group is one of the recommended regimens for high-risk patients, so absolutely would be reasonable. If my patient is interested in a fixed duration therapy, AVO is what I would do, and that study is published in JCO and it's listed on NCCN guidelines. If I don't want to use obinutuzumab, or if my patient doesn't like it, Sequoia D, which is also published and listed on NCCN guideline, uses zanubrutinib and venetoclax, but as I said, that would be also an MRD-guided approach of going longer with a treatment time if patients don't achieve the MRD. I did want to mention a practical point on the Notch1 situation. And, it's a high-risk feature. We saw some data on the Amplify as well. This is not part of any guidelines or practice, but we know that there is a dangerous combination of having Notch1 mutation, and when we do the IGHV status, if there is that 439 subset 8 stereotype, there is a significant high risk for Richter transformation very early. So again, this is not a large number of patients, but I think it's important because it could potentially be life-saving for patients. So I usually check the lymphoid gene panel at the diagnosis and also IGHV. If I see a combination of Notch1 by itself increases risk of Richter's per some literature, but if it's combined with that IGHV 439 subset 8, which is almost exclusively unmutated, I would start treatment as soon as possible, even if the patient doesn't have indication for treatment, to eradicate the clone with the combination. Again, this was a side point and not a very common scenario, but because this patient had that abnormality, I wanted to mention it.
You're saying a lot of things I've never heard before, which is great for me. I'm learning a lot here. I kind of not sure I've heard a lot about predictors of Richter's transformation before. Are there other predictors besides Notch1?
Well, I mean, in general, all the high-risk features for CLL are considered also high risk for Richter's, right? But this combination is not, you don't see it in a large number of patients, but papers published by the European colleagues, and we actually have clinical trials in some of the major centers, and some of our colleagues act aggressively on Notch1 mutated, but as I said, if you have the combination of both and you look at the curve of Richter's, it's a pretty impressive, not in a good way, curve. So the rate of Richter's is extremely high in that combination. So
I guess you're saying that 17p and p53 also predict higher rates of Richter's. What about, I've heard the term double hit, people with both p53 and del17p. Are they at higher risk for Richter's? Do you treat them any differently?
I don't think I treat them differently. I think, at least for me, having a p53 aberration of any form is considered high risk. I don't know if I am aware of any specific data indicating that at least risk of Richter's would be higher, but I may not know that. It may be there.
So final question. She mentioned this patient's issue with bruising. I'm curious what you see, and again, indirect comparisons in your clinical experience in terms of bleeding with Zanu, Acala, and also pirtobrutinib. Are there situations where you switch people off one of these agents because of bleeding to another?
Yes, I think bruising is, even with second generation BTKIs and Pirto, probably much less with Pirto. Well, this is now anecdote, right? I'm talking about my personal experience, which is limited. But bruising could happen. I have switched between the second generation BTKIs, and I can't tell you if any of these drugs. I can say pirtobrutinib, I don't remember seeing bruising, but with Zanu and Acala, I've seen them, and I've switched both ways. We had a prospective study of switching from Acala to Zanu, and in practice, in few cases, I've had switch from Zanu to Acala, and sometimes it helps. What it helps more is dose reduction, and that's one of the reasons that I think with zanubrutinib you have more room for dose reduction. So I tried dose reduction with second generation BTKIs before switching. If it happens on ibrutinib, obviously I switch immediately.
So this last case is what I call a real-world case, what you and everybody else sees in practice. A patient of Dr. Swaminathan, a 78-year-old man.
78-year-old man with a medical history significant for ischemic cardiomyopathy, on optimal medical therapy, PVCs, status post ablation 6 months ago, CKD Stage IIIB, and CLL, for which he was on observation for 6 years, presented for follow-up due to progressively worsening fatigue, intermittent abdominal pain, and night sweats. The CLL disease characteristics were as follows: unmutated IGHV, trisomy 12, and deletion 13q by FISH, and Notch1, BRAF, ASXL1, and SF3B1 mutations on NGS. The PET-CT showed widespread lymphadenopathy. Echocardiogram showed EF of 40%, and EKG showed left ventricular hypertrophy with no new STT changes. Because of the patient's symptoms, plan was made to start CLL-directed therapy. For this complicated patient, would you recommend a continuous treatment versus a fixed duration therapy? I started him on obinutuzumab. I gave him about 6 cycles, and he did achieve a partial response. And right now, the symptoms are very well controlled. and his portocaval lymph node, which was over 7.7 centimeter, shrunk to about like 2.5 centimeter.
What was your concern about not giving him venetoclax?
Because he did have a CKD stage IIIB, now we have data of using venetoclax even in patients with lower creatinine clearance. However, when we just see these patients in real world with 78 with associated comorbidities, not just the renal dysfunction, we tend to be on a safer side, especially when the patient's presented with a bulky lymph node of 7.7. We worry about possible tumor lysis if we were to go with the venetoclax combo. This patient, 78, with significant comorbidities, no atrial fibrillation, but does have PVCs and ischemic cardiomyopathy. Would you say this patient is not a good candidate for BTK inhibitor based on his cardiac history? And I also have a question about the choice of BTK inhibitor. Now, if we were to choose pirtobrutinib based on the data from Bruin 314 study, where we did exclude patients who had EF of 40 and below, would you consider using pirto in such patients who's otherwise borderline with the EF of 40 and just over 40, but otherwise seems to be doing reasonably well? I also want to ask, do you have any concerns of BTK inhibitor making ischemic cardiomyopathy worse?
So do you feel like you're on rounds getting a million questions here? This is like the art of oncology. I don't know if there's a right answer for this type of situation, but what are your thoughts?
I agree, and I wanted to highlight what you mentioned, which is in real world, and this is art of medicine, right? So you read the textbook and you don't see single agent obinutuzumab listed there these days in any guidelines, or maybe it's there at the end. But you have a patient and your goal is to get them back to their quality of life. Yes, monotherapy with obinutuzumab may not give you the longest PFS, but for this patient, I think it was a very reasonable choice. BTK inhibitors are probably okay in this setting in someone who doesn't really have a significant dysrhythmia, somebody who has a optimally treated ischemic heart disease and an EF that's borderline, but it's acceptable. But why would you take that risk if you can put a patient in a partial response at age of 78 regardless? I think obinutuzumab is reasonable. Venetoclax, I would probably be okay adding venetoclax if you put the patient through an antibody therapy and that first few months of intensive monitoring and clinic visits. I mean, this patient may have needed like a night or two in the hospital to be able to go on venetoclax. I'm not saying that it could be something I would consider, but I agree that why would we take the risk of adding a BTK inhibitor if we have other options? If I was going to use a BTK inhibitor, again, as I said, I don't know if I necessarily believe that pirto is the best in terms of cardiac profile, because acala and zanu are also pretty good. I don't know if I would use a strict EF cutoff for that, but as long as patient is cardiac optimized from the cardiac standpoint. And the key thing is to work closely with our cardio oncologists, and most of the practices either have one or if not, major institutions have. And these colleagues they're extremely experienced in using BTK inhibitors. And I always, when in doubt, I get a clearance from my cardiology colleagues. And remember, BTK inhibitors are the most important class in CLL treatment. So to exclude them from the treatment profile is we have to have a strong reason. So most patients are able to go on BTK inhibitor, but I 100% agree with the approach that was taken here. And I think it's interesting to remember this is coming from the major cancer center in the country, and still, despite the access to all the trials and all the drugs, that the decision for patient at the end of the day is something that is not necessarily what we think about. So important and very interesting case.
So getting back to BCL2, what about sonrotoclax? I know the ramp up there is not as difficult. Do you think for a patient like this, if it were available, just purely based on what they have to go through in terms of the ramp up, it would be easier?
I mean, sonrotoclax is currently under development and including the ramp-up schedule. The multiple ramp-up strategies are being considered. So when it's available, I think we do have actually a trial that we have here in Seattle. We're doing an inpatient daily ramp-up of sonrotoclax, which we're hoping to present in near future. So yes, when it's available, I think the way the drug is being developed, they're looking at a range of ramp-up strategies. So hopefully that gives more option than what we have with venetoclax now.
Yeah, I saw that accelerated ramp-up paper of yours. It kind of reminded me what they did at Ohio State also with venetoclax, but I haven't heard too much about that lately. One other issue in terms of, you mentioned arrhythmias, but specifically ventricular arrhythmias, which you maybe with this kind of patient might be particularly concerned about. I know there was some data with ibrutinib, I think maybe a little bit with acala, but where are we right now in terms of ventricular arrhythmias, including with zanubrutinib and pirtobrutinib?
So the ibrutinib is a different story, and unfortunately, the cases of sudden cardiac death / ventricular arrhythmias are, I think we see a small number of patients in different studies. With acala, I think the paper that you're referring to, probably the way the study was done, kind of combining some of the more benign ventricular rhythms to the more serious ones. Acala is also considered a very safe drug from a cardiac standpoint, so I wouldn't consider that drug something that's associated with ventricular arrhythmias. I think the three drugs that you mentioned, acala, zanu, and pirto, we have not seen in Alpine. We didn't see any cardiac deaths with zanubrutinib, which was great. And the rate of ventricular arrhythmias with either three, from my knowledge, is I don't remember seeing much or any. Pirto, I mean, even outside of the ventricular, even the AFib rate seems to be lowest with the current follow-up. So I think I would be comfortable with all three agents that we just mentioned.
So just a couple of final questions. I was reflecting back. I remember when I spoke with Dr. Ermann, who presented that first case of the patient who was on AV. And I think that patient had gotten it for 2 years. He was saying that he thinks he observed some kind of chronic issue with people on prolonged BTK, BCL2, in terms of side effects. Nothing specific like arthralgias or anything, but just sort of people don't feel well. When they stop, they feel better. And he was curious whether have you observed anything like that?
Yes, I think we do see, and that's important to consider when we're thinking about, because there's a lot of focus on, MRD positive, go another year. I mean, that needs to be balanced with not just the conventional side effects, but also patient-reported outcomes. I do agree that in combination doublets, oral doublets, we do see side effects, cytopenias, and fatigue towards the end of the treatment period. So it's something we need to pay attention when we get these upcoming results, MAJIC, Celestial, and other ones.
And related to that, final question, just curious where you think we're going to be, let's say 3 to 5 years from now, in terms of upfront management of CLL.
It's such a dynamic field. It's hard to predict next year, but I think I see us having very well tolerated and extremely effective all oral combos in the first line. That I hope we come up with a more user-friendly approach of, instead of having a complicated approach of MRD guided, just a simple version of, I don't know what's the right number, 12 months, 18 months, 24, and then observe the patient. I do think that we will be curing a lot of patients with that strategy and changing the current dogma of like CLL is not curable. And then in the relapse setting, with the introduction of classes like BTK degraders, we may have fixed durations even in the relapse setting. So combining, let's say, BTK inhibitor plus a BCL2 inhibitor upfront. In relapse, you use a degrader plus a BCL2 inhibitor maybe, and then there may be T-cell engagers that become available to even boost those. So that seems to be the direction we're taking, but hopefully we'll get great surprises of new classes coming too.
This concludes our series. Special thanks to Dr. Shadman, and thank you for tuning in. This is Dr. Neil Love for our CLL Microlearning series.